Guys, today let's start to understand thyroid hormone. Basically, it's a part of endocrinology, and we will be studying the physiology of thyroid hormone, how it is produced, where it is produced, why it is produced, and what's the function of thyroid hormone, right? So, thyroid hormones are of two types, T3 and T4, right? So, T3 and T4 they are made in where? In thyroid gland, right? So they are stored in something which is called as colloid, right? Now what is this colloid? Colloid is like a packet which has stored T3 T4, which are bound to something which is called as thyroglobulin. Okay, now why do you need to store this T3 and T4 with thyroglobulin? We need to store it so that this T3 and T4 are not in active form. Okay, because as soon as they get free from T3 T4, sorry, as soon as they get free from TG, that is thyroglobulin, they will start to react with other things. So we want to keep them safe, we want to keep them in a fridge, right? We want to keep them in a environment so that they do not react with their neighboring things. Okay, so thyroid, the main cell that makes the T3 and T4 is something called as follicular cell. It's follicular because on macroscopically you will look at the cell and they will look like this follicles, right? So that's why they were named follicular cells. Other thing, cells around these follicular cells were called parafollicular cells, and parafollicular cells they produce calcitonin. And calcitonin, the work of calcitonin is to tone calcium. It means to reduce the levels of calcium, because calcium is a signaling molecule. It can really affect a lot of things. For example, it can tell a cell that okay, it's time to die. So we want to keep calcium in check. So calcitonin is really important. Follicular cells make T3 and T4, and let's start with the synthesis of thyroid, right? So thyroid hormone, the synthesis starts from raw materials, right? So the step one is that getting raw materials. So the number one raw material for iodine, for this T3 and T4, is iodine, right? So iodine is present as iodide in our diet. Okay, so usually what happens is that a lot of brands they put this this advertisement that our salt has iodine in it. Usually you cannot have iodine, you need to have iodide in the diet. Okay, so iodide comes inside your body via the diet, and what happens is that you need something called as tyrosine residues. And this tyrosine residues, actually you can make your own tyrosine residues from RER, that is rough endoplasmic reticulum, that is present in your follicular cells. So follicular cells they make T3 T4 and thyroglobulin, right? So this thyroglobulin looks like this, and this is where it stores the T3 or T4, whatever it wants to store. So this thyroglobulin is made by our follicular cells, and then what happens is that this thyroglobulin makes tyrosine, and then you and we both need tyrosine to bind T3 and T4 for later production. Okay, so the flow of whole synthesis is this, that everything, okay, all nutrition, all raw material that is present in the blood, right, from our diet, right, it comes from the basolateral side. So basolateral side is the blood side, right, and apical side is the lumen side, right? What is a lumen? Lumen is like an empty space. It's like a tank, empty tank. Okay, and basolateral means base means base, and lateral means lateral. So blood side is basolateral side. So from the basolateral side we get everything, right? Every nutrition, everything that needs for the formation of T3 T4, it flows across the cell from basolateral to apical in the form of colloid, right? Because I told you T3 T4 are stored in colloid form. So they form like this, they go to basolateral to apical. Once they reach to apical, all the synthesis of T3 is done. When T3 T4 is done synthesized, what happens that this T3 T3 T4 gets inside a colloid, and then this colloid goes back inside the cell, right? So it's really unique because not a lot of glands do that. Because what is happening basically here is that this synthesis of T3 and T4 is happening extracellularly, right? It's really unique. Not a lot of glands do that. Not a lot of endocrine glands do that. So basically, what the work of follicular cell is to provide the basic nutrition, basic iodide, basic tyrosine residue. Okay, that's the work of follicular cells. So if you have any sort of gain of function in follicular cells, what will happen is that we will have a lot of iodide and we will have a lot of tyrosine residue. Once we have this residue, we will make a lot of T3 and T4. So the basic function of follicular cell is to collect the iodide and tyrosine residue of this synthesis. Okay, so this is the work of follicular cell. So let's dive deep into the synthesis of this hormone. So step one is that there is a there is a there is a port, right? There is a gate. It's called Na, sodium iodide symporter. Symporter means sim means same. Okay, porter means it ports, right? It follows, it carries. So symporter means both the things are going inside. Anti-porter or anti-porter means things are go flowing on the opposite side. So symporter, so there's a Na and iodine symporter. What happens is that both the things they get inside. Two molecules of Na and one molecule of iodine, they get inside the cell, right? And why does it works? It works on the pressure gradient that is generated by this pump called 3Na and 2K pump, ATPase pump. Now I am saying this ATPase because it uses something called as ATP, right? So imagine if you have low glucose levels. If you have low glucose level, you won't be able to make pyruvate. Once you have low pyruvate, you won't be able to make ATP. Once you have low ATP, you won't be able to use this ATPase pump. So once this ATPase pump stops working, what happens is that the function of this ATPase pump is to maintain low Na levels, so that Na, the sodium, is outside, right? Extracellularly it's more, right? So that this importer can take this Na and put it inside, right? Because we need this large quantity of Na outside to transport iodine with it. Okay, iodide, not iodine. Okay, so once the step one is over, once the Na and iodide are already inside the follicular cell, what happens is this iodide travels to the pendrin porter, right? So this pendrin porter is actually an exchanger. It's a anti-porter. What happens is that flow of one element is this way and another element is this way. So this is the flow of this. So what happens is this pendrin exchanger actually exchanges one molecule of chlorine and one molecule of iodide, right? Now note that this iodide, this one molecule of iodide, is in the reduced form. It means it's not active. Okay, we cannot still use it. We have to transform this iodide into a active form of T3 and T4. Okay, we need to do that. Now all of the story is happening in the lumen side. We need to understand this. Okay, because all the raw material, all the basic things are in the blood. The things get inside the follicular cell pushes these things on the apical side, which is the lumen side, and then this thing happens, right? The synthesis of T3 and T4 happens. Once we have the iodide present and the lumen side, what happens is that this iodide actually undergoes oxidization, and this oxidization is done via something called as TPO. What is it? It is thyroid peroxidase, right? So this TPO, this thyroid peroxidase, is actually, it works. It's a catalyzing worker. It oxidizes this reduced iodide, and once it oxidizes this reduced iodide, it becomes oxidized, right? So it becomes I2, that is oxidized iodide, and this part is reactive now. So this iodide is now reactive. Okay, so once this iodide is reactive, what happens is that there is uh, another thing going on. What is this thing? There's something called as organification. Now this organification is this, that when this organification happens, so what is organification, by the way? This organification is that this inorganic, you know, this iodide, this inorganic iodide, that is the I2, or this I2 iodide, this inorganic iodide, it's oxidized, right, with TPO. We get oxidized TPO, sorry, we get oxidized I, we get this oxidized iodide. So this oxidized iodide plus tyrosine residues, right? I told you guys earlier that tyrosine is made from RER, from the follicular cells, the rough endoplasmic reticulum. Why they are rough? Because they are rough because they have some granules, okay? Now these granules, they make the appearance rough, okay? If these granules are not present, we call it smooth endoplasmic reticulum. Okay, why we call this endoplasmic? Because they are inside the plasma, not inside, they're within the plasma, so they are endo. Okay, so RER and SER, we understand it. So what happens is that this inorganic iodide transforms into oxidized iodide with the help of TPO. Now this oxidized iodide plus tyrosine residues from RER, right, it transforms into organic form. Organic means it has a carbon molecule, right? This, or it means we can use it. So this organic molecule, it becomes, right, with the help of tyrosine plus one molecule of iodide, we get mono iodide, okay, MIT. If tyrosine plus two molecules of iodide, we get duo, sorry, not dva, duo iodide DIT, right? So D stands for duo, M stands for mono. So mono means one molecule of iodide. Duo means two molecules of iodide. So we get MIT and DIT. And note that these two forms are organic form, right? They both are organified iodide. Okay, it means they are already with tyrosine. Okay, so all of this happens with the function of thyroglobulin, right? All of this is happening when they are already connected with TG, right? I already told you TG, about TG, thyroglobulin, right? Okay, so this organification happen means MIT and DIT is formed. Now this MIT and DIT again go into something called as coupling reaction, right? So first reaction was oxidation of reduced iodide. Later, this oxidized iodide got under organification where MIT and DIT are formed. And now this MIT and DIT are going under coupling reaction. Why do they call it coupling? Because they are getting coupled, right? They're getting coupled, it means they are forming a group. So MIT plus DIT, it means 1 plus 2 equals to 3. Okay, T3, we get T3. DIT plus DIT, 2 plus 2 equals to 4. So T4, right? Now imagine if I swap this, right? If instead of MIT, I write DIT, and instead of DIT, I write MIT. Now I am swapping, right? We still get T3, but it's a reverse of T3. So reverse T3. Now this reverse T3 is inactive because iodine atoms are attached at the wrong ring, right? This is the internal ring. So this is the concept of reverse T3, T4 and T3. T3 is DIT, MIT. T4 is DIT, DIT. And reverse is this, that you reverse this. Reverse of T3 is reverse T3, right? So we call it coupling reaction. So now once we are done with the coupling reaction, what happens is that this coupling reaction, note, now another cool thing about this whole thing is that this whole thing is happening inside the mitochondria, right? So now we get now we get Ti3, now we get T4, now we get reverse T3. So now this T3 and T4 and R3, this reverse T3 are bound to TG, that is thyroglobulin. Now I have already been telling you again and again that this whole thing is bound to this TG, right, thyroglobulin, because we want it to be stable. If this is free, then it will not be stable. So TG is binded with T4, is binded with T3, is binded with reverse T3, is binded with MIT. What is this MIT? You must be thinking where this MIT comes from, where the MIT is coming from, right? Because we already use this. but we don't use all of MIT. We don't use all of DIT. These are MIT residues. These are DIT residues. So thyroglobulin is still attached to all five things. And this whole thing is called a colloid. So this colloid goes back inside the cell, and this colloid stays inside the cell for next 2 to 3 months, so that you can have, a good level of T3 and T4 in your body. So that is the synthesis of T3 and T4. Okay. So that was the synthesis of T3 and T4. Now, what can happen is that we can have this broken symporter, we can have this broken ATPase, we can have this broken pendrin, we can have this broken organification. We can have problems at every step, right? So let's try to discuss and let's try to understand what really are the problems of this whole story about thyroid, right? Okay, so mechanism. The mechanism is this. I already told you that sodium iodide symporter is present right here. Location is basolateral, of course, at the blood, because all the nutrients comes from blood. Function is to iodide trapping, of course, with Na, with 2 Na, 1 iodide is trapped inside the cell. Type is, what is type? It's a type means what kind of transporter it is. Is it active or is it passive? Now it's a secondary active transporter. It means this was primary active transport. Okay, it has created a concentration gradient higher here and lower here. So obviously things will move from higher to lower because of the concentration gradient. Okay, so this is a secondary active transport, right? Secondary, as Na concentration outside the cell is high. Now using this gradient, the iodide is trapped inside the cell. So that is the concept of secondary active gradient. Other locations are salivary glands, mammillary gland, and placenta. We'll talk why. Salivary glands, right, are salivary gland, parotid gland. At the parotid, the iodide is put inside the saliva, and it's a reflection of your plasma iodine level, right? Usually salivary glands puts the iodide into your saliva, right? Other thing, memory glands, right? Boobs, right? Breast. What happens is that breast, it puts the iodine inside the breast milk so that the neonate can have enough iodide, so that he or she can make enough T3 and T4. In the placenta, there is again the this iodide can actually cross the placenta barrier, and we need that iodine, we need the T3 and T4 for the development of this neonate, right? So that's why placenta can produce these symporters, iodide and sodium symporters, right? Okay, let's talk about Wolff-Chaikoff effect. Now what happens in this Wolff-Chaikoff effect is that there is excessive iodine through NIS, right? So there is a gain of function here. Now once there is a gain of function, what will happen is that excess iodine through NIS will come inside the cell. Now this will inhibit the organification of T3 and T4, right? Organification means formation of MIT and formation of DIT. So once there is a lot of iodine, inactive iodine inside the cell, it will give the function, it will give the signaling, right? It will give you a negative signaling that, hey, we already have enough iodine, we don't need to make more T3 and more T4, we don't need to make more MIT, more DIT. So this is called Wolff-Chaikoff effect, right? And we can actually use this, we can give patients a lot of iodine, a lot of inactive or active iodine, and tell the thyroid to stop producing T3 and T4, so that the vasculature of this gland reduces gradually, so that we can perform various surgeries that are needed, that are needed for maybe cancer, that are needed for maybe removal of any adenoma there. So this is why we need it, right? So another thing that I've written is 2 to 10 days, right? Think thyroid as a sponge. Okay, so this effect works for 2 to 10 days, right? It works as sponge because once you give it enough, it will stop making, right? Because the thyroid is already getting enough iodine. So where's the use? It uses it this effect is used in the in the treatment with Lugol iodine. We give this something called as Lugol's iodine prior to thyroid surgeries, and it's less perfusion of the thyroid gland happen. So what does it mean, less perfusion? It means less blood flow, right? Because T3 and this thyroid is less metabolically active because we are giving a lot of iodine already, and we are doing something called as Wolff-Chaikoff effect, right? It takes around, this thing stays around for 2 to 10 days. Okay, so we can use this, we can abuse sodium iodide importer by giving a lot of iodide, right? Okay. uh, let's see. uh, Iodide, what is iodide, how this happens, blah blah blah. So iodide, chloride, antiporter. Antiporter means against, or against the importer, right? It's exchanger. Okay, it exchanges chloride with iodide. It pushes off the iodide outside the extracellular membrane, and it pushes in chloride inside the cell, right? So that we can push iodide, right? So that's the concept of this, and we call it pendrin, right? Now this pendrin is present at the apical side, right? It's lumen facing, right? So location is thyroid gland. It's present in the thyroid gland, and it's present in the inner ear. Why? Because we know that physiology in the inner ear produces something called as endolymph. Now this endolymph is very important for, um, very important for depolarization of hair particles, not hair particles, depolarization in the ear, so that the conduction of sound waves can result to electrical formation of electrical signal that can go to that can go inside the brain, right? So this cochlea makes endolymph, and this endolymph has pendrin. Okay, so what happens is this endolymph is present in the cochlea, and then we call it something called as pendrid syndrome, where the pendrins are not working. So if the pendrid are not working, you will have less T3, T4, because you will not get iodine on the apical side. Second, you will have something called as hearing loss, because endolymph, the production of endolymph involves pendrin, and once pendrins are not working, the production of endolymph will succumb to a stop, succumb to a halt, and then you will have less conduction of, ear, less conduction of sound. That's what gonna happen. So mutation of pendrin can result to pendrid syndrome, results to goiter, results to sensorineural hearing loss. Okay, and this is the story of pendrin. Other thing, thyroid peroxidase, TPO, right? TPO is needed for a lot of things. TPO first is needed for oxidation of reduced iodide into oxidized iodide, oxidized reactive iodine. Other thing that TPO is needed is for organification as well. Okay, not organification, I'm sorry, it's needed for this this oxidation, right? Let's see what TPO is needed for. So TPO is needed for oxidation, iodine oxidation is needed for organification. I already told you it's needed for organification. It's needed for coupling reaction. So TPO is needed for almost everything, almost for organification, for coupling, for this this oxidation. So TPO is needed. Once you have bad TPO levels, it means that you will have bad T3 and T4 levels, right? So if TPO is not working, no oxidation, no T3, T4. So how can we how can we stop it? We can, there are something called as anti-thyroid drugs. They work by stopping TPO, and we have something called as propyl thyrosyl carbimazole methimazole. Now we give this drug in hyperthyroidism, right? Hyperthyroidism means your thyroid is making more and more T3 and T4, right? So we need to stop production of T3 and T4, and we can give carbimazole, methimazole. So all the zole shit we are giving, we can, stop the production of T3 and T4. The regulation of T3 and T4. Uh, the regulation is done by negative feedback loop. I will tell you how. What happens is that actions of thyroid stimulating hormone, there is something called as TCH, not TCH, TSH. TSH means thyroid stimulating hormone. So this thyroid stimulating hormone goes to thyroid and it tells the thyroid to make more T3 and T4. If your levels of T3 T4 are low, there we will have more TSH. If your levels of T3 and T4 are very high, you will have low TSH. Okay, that's the concept. So this TSH increases vascularity of the gland, right? We need more production of T3. Production of T3 T4 more, iodide trapping, sympoters increases. So that's the work of TSH. What happens is that hypothalamus produces TRH, right? And this TRH, it stimulates this anterior pituitary, and this anterior pituitary produces something called as TSH, and this anterior pituitary produces TSH, and this TSH goes to your follicular cells and tells to make T3 and T4. Now once you have enough T3 T4, a negative inhibition loop starts. This T3 and T4 inhibits first anterior pituitary, then the hypothalamus, it stopped, right? So if we have a lot of T3 T4 levels, because we have some sort of adenoma here in the follicular cell, we will have a low level of TRH, we will have low level of TSH. Okay, so that's the concept behind this regulation. Okay, once the T3 T4 are produced, they are stored in colloid, right? Now the exocytosis of colloid happens, right, with the help of calcium and SNAPE proteins. So this colloid breaks down, and this T3 and T4 are outside, right, released into the blood, right? What I've written is that okay, I will tell you why the binding is needed. Okay, so binding proteins, it means there are three binding proteins. One is albumin, second is thyroid binding globulin, and third is pre-albumin. It means just a stage before albumin, or something called as transthyretin. Okay, so this transthyretin is cool because I will tell you why. Okay, so this 99% of T3 and T4, they bind to something called as this thyroid binding globulin, because its name suggests that it binds to globulin, right? And then we have around 0.5% to albumin and 0.5% to pre-albumin, right? Okay, so this 99% is bounded to the protein. Why there is 99% is bounded? Why it is bounded to the protein? Why don't we have more levels of free T3 and T4? The main reason is that T3 and T4, both of them are very catalytic hormone. They are going to break a lot of things. They are going to break your fat. They are going to break your muscles. They are going to break a lot of, things inside your body. So we don't want more levels of T3, T4. If we have more levels of T3, T4, we will lose a lot of weight. We will lose a lot of function. It's a catalyzing hormone. It stops. It destroys. It's not anabolic in nature. It's not. It's the opposite of insulin. Okay. So these are polar hormones, T3 and T4. It means they are charged, right? Thyroid is lipophilic hormone, right? It's a lipophilic, just like steroid hormones are also lipophilic. They can go inside the the bilipid layer of any cell. They bind to protein to keep them soluble. Okay, lipophilic, it means they are it means they are phobic of water. They hate water, right? Because either a hormone can be lipophilic or it can be phobic of to the it can be insoluble, basically insoluble. So if a hormone is insoluble in water, it means it's soluble in fat. Okay, if a hormone is soluble in fat, it's insoluble in water. If a hormone is soluble in water, it means it's insoluble in fat. It needs some sort of second messenger. That's the concept. So binding with protein keeps them soluble in water, keeps them soluble in blood. Binding creates reserve, right? And prolonged half-life also occurs. Okay, prolonged half-life means increased half-life. What is half-life? Half-life is just the duration of for example, I give you a drug, I give you 10 milligrams, right? And it stays in your body for 10 hours. So what's the half-life? 5 hours is the half-life. So in 5 hours you will have 5 mg, right? And in next 5 hours you will have in next 5 you will have okay, I'm so done with this lecture, honestly, because it's taking way long. I I, I hope you understand half life. It's not a very tough concept, honestly. Colloid breakdown breaks down bounds to albumin, thyroid binding globulin. Okay, okay. TBG has highest affinity, loves this T3 T4 a lot, right? Okay, pre-albumin. It's not albumin. It's pre-stage of albumin. We have something called this trans means throughout. Thyretin. Retin means vitamin A. Thigh means T3 and T4. So these are vitamin A, proteins usually, and these are, so if we have less levels of vitamin A, we will have less levels of trans thyretin, and if we have less, the basically T3 T4 won't bind, right? So that's the story. Okay, so receptors, what happens that this is blood. T3 T3 are bounded with these. If they are bounded, they will not react to the receptor. If they are in the free form, 1% is free, responsible for the action. So the 1% T3 T4 is here. Now we have something called as MCT and OATP, right? These are two receptors, and these receptor full form is that monocarboxylase transporter. Okay. Second, OATP is organic anion transporting peptide, OATP and MCT. So MCT binds with T3, OATP binds with T4. Once they are binded, they go inside, because we know that T3 and T4 are lipophilic, right? They can cross the membrane. Once they cross the membrane, they get inside the cell, and then they right away go to nuclear receptor. This is nucleus. It has a receptor for T3 and T4. So there is no second messenger because it's a lipophilic hormone. I am saying this again and again. Okay. So it binds to nuclear receptor, then the formation of mRNA happens, then there's gene transcription, and then blah 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 blah. RER makes new genes. So T3 and T4 lead to formation of new genes, right? Genetic result, right? So works via nuclear receptor mediated, right? T3 T4 are lipophilic, we know that, and they can alter transcription, right, in the nucleus, in the DNA. Okay. RNA makes new genes, blah 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 blah. We know this already. So the most important thing here is that they have two receptor, MCT and OATP. MCT is mono, OATP is anion transporting peptide. So again, important thing, they work via nuclear receptors. Okay, they don't have any second messenger because they are lipophilic, both T3 and T4. Okay, cool thing. Differences between thyroxine T4 and triiodothyroxine. Okay, right? Triodo means T3, thyroxine means T4. So difference between T3 and T4 is that T3 is more potent. It means it gives more effect in less quantity. Again, if it's less quantity, why is less quantity? Because the half-life is 1 day. In 1 day, the storage, the substance, it get reduced to its half form, half quantity. For example, I had 500 grams, it will go to 250 grams. So 1 day it gets reduced to half. T4 is 7 days. In 7 days, it reduced to half. Plasma, again, if it's more potent, means it is more free. It means it is less binded to the plasma protein. It is more tightly binded. Action is high if it's more protein, rapid action, long acting, right? Quality in quantity, it means it's less in T3. It means it's less because if it's more potent, means it's free outside, right? It's least potent means it's binded already, right? We know that T4 is DIT, and T3 is MIT plus DIT. 1 plus 2, not 2 plus 1. It will give reverse T3. Okay. Form, we know that this form means, what does it do? It actually goes into physiological forms, right? For example, it gives us metabolic actions, and this T4 gives us pharmacological actions, means drug form, right? What else? The reference. So I hope you understand. T3 is more reactive. T3 is more potent. That's why T3 is less in quantity and T4 is more in quantity. Okay. Okay. Peripheral conversion, not conversation. Peripheral conversion of T3 into T4. Blyaj. Peripheral conversion of T4 into T3, because we have a good storage of T3, so we want to convert some T4 into T3. Yeah, right. So once T4 is converted into T3, we have enough T3, and then we can use this T3 for the physiological benefits. So T4 is converted to T3 with the help of something called just deiodinase. Iodinase means it's breaking down something. From T3, it's breaking down into T. Oh my gosh! From T4, it breaks down into T3. Okay, so this contains what we'll talk. So what happens, this deiodinase, right? It contains something called as amino acids. What amino acids? 21 amino acids. Okay, it contains amino acids, 21 amino acids. It contains selenocysteine. Now cysteine, but the sulfur atom is replaced by selenium. That's called as selenocysteine. Now what happens is that this selenium is more reactive, so it catalyzes faster than usual. And if there is deficiency of selenium in your diet, the deiodinase activity will go down. There will be less conversion from T4 to T3, and you will have less peripheral conversion, not conversion, right? So deficiency of deiodinase results to less T3. So eat selenium plus iodine for good levels of T3 in your body. Okay. Action mediated by mostly physiological actions are done by T3. Mostly pharmacological actions are done by T4. Right. So what happens here is that T3, it increases BMR. Okay, it increases uncoupling. Okay, well, I'll tell you what is uncoupling. It's very simple. it it is a catabolizing hormone, I'm telling you again and again, and it affects on glucosaminoglycans. Okay, gags. I will tell you what is gags. It's very simple. And during, we need T3 for the brain development and bone growth. Okay, and on heart, T3 increases heart rate. I'll tell you how. Norepinephrine. And on lungs, it also increases the lung. I'll tell you what happens, that the metabolism increased, the O2 consumption, O2 requirement increases. It results in hypoxia. Well, I'll tell you blah 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 blah. In GIT, T3 increase the, basically what happens is that, just imagine that T3, I will tell you very simply, you don't have to remember all of that. T3 is like how to say this, T3 is like cocaine. Okay, I'm not saying this physiologically is like cocaine. It works as like cocaine. Just imagine someone ingests cocaine. They will be super active. They will go into catalytic stage, right? They will go into active stage. Their BMR increases, their heart rate increases, their metabolic requirement increases. They start hyperventilating. So, right, T3 is like this, right? It's like they're on drugs. They're like hyper, right? Hyper. And low level of T3, it's like hypo. It means they get fat. They don't want to move. A lot of lipogenesis happen. A lot of fat is made, right? So actions, let's start fast. So BMR increases. Okay, how? So increased metabolism even at rest, BMR, right? Basal metabolic rate. So this result to O2 consumption, right, throughout the body except brain, because baseline BMR already high in the brain. So, right, and imagine if just one dose of T3 can screw up your brain, right? You're screwed, you're messed up. So you need your baseline brain to be normal throughout your body. So brain needs to be more stable, right? So that's why brain, it will not work. Except other thing, so except adult brain, right? We know in testes, if we take T3, there's no effects gonna happen. Why? So that more T3 exogenously won't make you jacked or smart, right? Like how TRT works. It's not testosterone replacement therapy, right? It's T3, right? So testes, they are not gonna work. On uterus, nothing's gonna work. Why? Because they're metabolically low, right? They don't need a lot of blood supply, but they just need a lot of blood supply when you have nausea, right? When you have periods, when you have bleeding in the endometrium, right? Another thing is spleen. So body can't leave immune status on mercy of T3, right? If we have if you have more T3, we don't want some weird things happening with your immune system, right? So that's why brain, testes, uterus, and spleen are not affected by T3. Okay, so metabolism increases, need of O2 consumption increases, so metabolic end product will also increase, right? Once the metabolic end products also increase, it means, what is metabolic end product? It is just trash that your body creates. So vasodilation will happen. Once the vasodilation can happen from the metabolic end products, right? It happens in where it we see this happening during exercise. When we exercise, a lot of metabolic shit products, for example H plus, K plus is synthesized, and to throw this out, our body does something which is called vasodilate, right? So once the vasodilation increases, the peripheral vascular resistance, it drops, right? The resistance, it drops. I hope you understand peripheral vascular resistance. Peripheral vascular resistance means, peripherally means your hand, your legs, right? Vascular means vascular, and resistance is the resistance that is given by your arteries, okay, against the blood. Okay, so blood can easily flow now, okay, because we have a lot of H and K plus ions inside our body because of the high metabolism. Okay, that's why any organism with high metabolism is going to die faster. This is the reason why high metabolic animals, they die faster. For example, a housefly, the metabolism is so high that it dies in one day. So that's why. Physiological uncouplers, it means T3 stimulates something called as uncoupling protein 1, UCP1. Now this UCP1 is used for production of heat, not production of heat, dissipation of heat. What happens is that T3, right, it dissipates a lot of heat, right? And this heat, thermogenic action, increase in heat, right? So if there is hyperthyroidism, it means T3 is more, this guy will feel a lot of heat already, so he cannot go to India, right? Because India is usually a very warm country. So what will happen is he cannot tolerate this heat. If a woman has hypothyroidism, she has problem with heat generation, right? Why? I don't know why it's written heat generation. It's not heat generation, it's heat dissipation. So what will happen is that less heat dissipates, right? Or more heat dissipates, right? So hypothyroidism leads to cold intolerance, because she's gonna feel cold all the time, because BMR, the basal metabolic rate, is low, right? So heat generated by his body to make sure that she is warm, the shell temperature of this body, of this woman, is low, right? If this is low, it means she's not gonna be comfortable in a country like Kazakhstan, because here the temperature in winters is like -44. So that's why we need less. That's why hypothyroidism can be a big problem in women. Other thing is catabolism. Catabolism is just breaking down stuff. Okay, so carbohydrates metabolism, glyconeolysis, right? What happens is that carbohydrate metabolism is affected. It means that glycogenolysis, okay, it's happening. It means more blood glucose from the pancreas, liver, is going into the blood, right? And so it's increasing. So T3 is increasing blood glucose, right? Now it is not diabetogenic, because this question came to my mind, because if T3 is inducing diabetes, it means everyone is hyperthyroid patient. So every hyperthyroid patient will have more sugar levels, but it's not like this. Because just imagine you're breaking down stuff. What will come out of this stuff? Of course, glucose will come out of this stuff. So this glucose comes out and stays inside the blood, and it's not diabetogenic. It means it doesn't impair insulin sensitivity, because diabetes is a disease of insulin. It's not a disease of glucose. Okay. Okay, lipid metabolism. A lot of lipids will be broken down. A lot of carbs will be broken down. A lot of protein will be broken down. A lot of cholesterol will be broken down. Lipid is lipolysis, proteolysis, protein. Cholesterol is the levels of blood cholesterol goes down, right? Because why? Because cholesterol is getting catabolized, right? Now, if the imagine if the cholesterol is getting catabolized, right? There will be low levels of cholesterol in the body. Right now, it is good and it is bad. It's bad because you won't be able to move. First of all, you won't be able to make any sort of steroid hormone or any sort of adrenal hormone. Okay, so a lot of hormone synthesis will be stopped in this thing called hyperthyroidism. Okay, so hyperthyroidism, no adrenal gland functioning because all of the adrenal gland hormones are made from cholesterol. So this is problem. Another problem is in hypothyroidism where T3 levels are low. It means cholesterol level are high. It means the metabolism of cholesterol is stopped. The catabolism is stopped. Once the catabolism of cholesterol is stopped, it means the level of cholesterol in your blood increases. Once the blood level of cholesterol increases, you will have high risk of atherosclerosis and heart diseases, right? So fat people, they get atherosclerosis and heart diseases. They are fat because they have hypothyroidism and they eat a lot of calories. Okay, they are not fat because they have hypothyroidism. They are fat because they eat a lot of calories. And this lot of shit calories actually results in hypothyroidism. So once they stop eating shit food, they will have some resolution in this hypothyroidism. And once the resolution happens, they will not have high risk of cholesterol and they will have low risk of atherosclerosis and low risk of heart disease. Effect on glycosaminoglycans, GAGs. So what happens is that it's very interesting, super amazing thing. So there is something called as T3. Now I will tell you why this goiter happens, right? Goiter, have you seen goiter? Goiter is like this edema. Okay, it's like edema of this neck, edema of this thyroid gland, edema of this, right? So what happens that T3 prevents accumulation of GAGs, right? Now what is GAGs? What is glycosaminoglycans? These are hyaluronic acid, AA. Why do we need hyaluronic acid, by the way? Hyaluronic acid, we need hyaluronic acid for the formation of COX and 5-oxysynthase or something like that. That usually results in leukotriene formation and just inflammatory mediator formation. That's why we need hyaluronic acid. So what happens is that these are proteins, right? Glycosaminoglycans, right? These are protein with this protein with sugar, right? So accumulation of GAG happens, right? It prevents, T3 prevents, because T3 is a catabolic shit, right? So it catabolizes, it moves shit. So T3 prevents the accumulation of GAGs, hyaluronic acid, chondroitin sulfate, right? Once T3 levels go down in hypothyroidism, accumulation of GAG will happen. So these are proteins, right? If you have leakage of protein from intracellular to extracellular, of course water is going to follow this protein because water follows something called as diffusion, right? So water follows and then you have something called as swelling up, and then we call it mixed edema combining with water, right? So these GAGs are negatively charged ion. They attract water and sodium because they are negatively charged, right? They are negatively charged, right? So they attract sodium, positively charged, and we know that sodium attracts water, right? So that's why we have something called as non-pitting edema. Non-pitting means you just press the surface of the edema and then there is no formation of any crater or any formation of how to say this. It's a non-pitting edema. Try searching it on Google. During development, wow, it's a long topic. Okay, so during development, what happens that we need T3 for good brain growth. Okay, because T3 results in formation of myelin. Myelin is this fat layer on neurons. We need fat on neurons. Other thing is bone formation. We need bone formation, right? If we have low T3 levels, it will be retardation in the child. Okay, what will happen is that we have something called dwarfism also can happen. Okay, you have something called a stunted growth. So T3 needed for not needed for stopping the mental retardation. Most common is reversible cause, right? And low IQ, once you start giving the patient T3, the mental retardation will resolve. But the stunted growth will not resolve once this guy or girl has crossed the age of 18, 19, this stunted growth will not be reversed. On heart, T3 acts via increasing norepinephrine. Okay, let's see. Increasing responsiveness of heart, circulating catecholamines, norepinephrine works via beta receptor, and this beta receptor can be stopped by beta blockers, propranolol. Okay, why? How? So increase heart rate via beta 1 receptors. Okay, increase stroke volume. Again, we know T3 is catabolized. It increases the level of norepinephrine. It's a catecholamine. This increased levels of norepinephrine goes to beta receptors and it increases heart rate, increases stroke volume. What is stroke volume? Stroke volume means on every stroke how much volume of blood the heart is pushing. So that's stroke volume. Other thing that cardiac contractility increases, right? It's there is a very good word for this, cardiac contractility. So increased cardiac contractility. So there is something called a thyroid storm. What is thyroid storm? Thyroid storm means a lot of level of T3. Mean dangerous level of T3, right? Someone commits suicide. So T3 increases. A lot of epinephrine, norepinephrine levels. There are dangerous levels of heart rate, right? Like 200 plus. So imagine if your heart is beating at this speed, you will not be able to. What happens that paradoxically the stroke volume goes down when the heart rate is very high. So we give, in this case we give beta blocker called propranolol. Okay, this is the whole story. On lungs, what happens that T3 increases the metabolism of the whole body, right? BMR increases. Once the BMR increases, you need more O2. Now lungs cannot cope up with this, so what will happen is hypoxia will happen. Now once the hypoxia happens, it will stimulate respiration and then you will have tachypnea, that is increase respiratory rate. Now the shift of O2 dissolution curve chooses to right. So there is O2 dissolution curve, it's like this. Okay, now this curve can go to right, it can go to left. On restrictive disease it goes to right, on obstructive it goes to left. Okay, so shift of O2 goes to the right. On GIT, we know that if the BMR is high, the patient will be high on cocaine. It's not high on cocaine. I'm not saying that it's like similar. I just want you guys to like understand and remember this T3 and T4 shit, right? So if T3 increases, you will have diarrhea. If T3 goes down, you will have constipation. That's the whole concept. So GIT increases motility, right? Motility means movement. GI secretion increases, right? On hypothyroidism, low level of T3, low motility, constipation. Okay. On T3 increases, diarrhea happens. T3 decreases, constipation happen. Okay. Productive system, reproductive system. So T3 is, we know that T3 messes with the cholesterol, right? And increased T3 results in breaking down of cholesterol. It means low level of cholesterol, and we need cholesterol for making sex hormones. So again, sex steroid hormones will not be formed, right? So permissive role in normal reproductive function in liver, T3 increases sex steroid binding globulin, right? So T3 equals to less cholesterol. Less cholesterol equals to less sex drive, less libido, right? So this is the formation, right? I hope you understand the whole story of T3, T4, because I really try to explain this in very details about every word, everything. So I hope you guys understand this really simple T3, T4, why we need it, where it's formed, what is pendrin, what is colloid, what is this importer, and what is Wolff-Chaikoff, increased level of, you give a lot of iodide and then this T3, T4 shuts down. Not T3, T4, thyroid shuts down, and we can use this for thyroid surgery, right? And we use Lugol iodine, right? We give Lugol iodine to the patient so that shutdown of this perfusion of the thyroid gland happens, right? And I hope you understand thyroid peroxidase, TPO. I hope you understand the negative feedback loop. Most homeostatic regulation is negative in terms of endocrinological endocrine function. Okay, I hope you understand binding proteins. What are the binding proteins? Why do we need binding protein? There is only one important binding protein, that is thyroid binding globulin. other is albumin and other is pre-albumin, right? I hope you understand this MCT and OATP. OATP is for T4, MCT is for T3. I hope you understand. T3 is potent. Why it's more potent? Because it's stored, because it's free. That's the, because chemically it's not, it doesn't, why T3 is chemically more reactive? Why? Well, it it follows something called as octet rule, and T3 is not stable because it's not stable, right? I hope you understand T3. D4, we know that, okay. Deiodinase, it breaks the iodine, right? It breaks T3 into T4 into T3. Selenocysteine, we know selenium for the formation of deiodinase, right? I hope you understand this. BMR increases, uncoupling reaction, it increases, heat dissipation is increases, right? If you have high BMR, you will generate more heat. Usually fat people are really really cold, because they generate less heat because they are suffering from hypothyroidism. Catabolism, it means breaking down of carbs, breaking down of lipids, breaking down of protein, breaking down of cholesterol. Your sex life will be messed up if you have low levels of T3 or T4. GAGs, glucosaminoglycans, GAG, they are negatively charged ion, they attract Na and water, and then we have something called as goiter. These are non-pitting edema, okay? We call it mixed edema plus combining with water, okay? Development, for brain growth we need T3, for bone growth we need this T3. Brain retardation is reversible. Once you give T3, brain will be normal. Again, T3 doesn't affect your testes, doesn't affect your brain, doesn't affect uterus, doesn't affect what else? It doesn't affect spleen, right? I hope you understand the reason why it doesn't affect GIT. We understand it increases the BMR levels of GIT. On reproductive system, we know low level of cholesterol because of high levels of T3, because the catabolism of cholesterol is happening. I hope you understand the whole topic. It's very simple, but I don't know. I hope you understand it. Have a nice day.